Welcome to the chapter on evidence-based neurostimulation for pain. The purpose of this chapter is to summarize the major neurostimulation procedures used to treat chronic pain, review the evidence available supporting the use of neurostimulation to treat specific pain syndromes and its limitations, and finally to briefly discuss the future directions of neurostimulation for pain. Based on calculations from 2008, the estimated prevalence of chronic pain in the United States is 100 million, resulting in a loss of productivity and adding approximately $300 billion to the cost of healthcare annually. Chronic pain is gaining recognition as a complicated ailment, one that encompasses sensory, emotional, and cognitive domains, and is challenging to control with pharmacology, physical, behavioral, and psychological therapy in isolation. As a therapy that lacks the addictive properties and side effect profile of commonly used analgesic drugs, neurostimulation is an attractive option for treatment of chronic pain with the added benefits of being reversible, testable, and possessing the ability to be tailored based on the individual needs and unique response of each patient. The justification behind the first use of neurostimulation to treat pain stems from the gate control theory developed by Ronald Melzack and Patrick D. Wall in 1965. They proposed that nociceptive input transmitted by small diameter C and A delta fibers could be inhibited by the activity of large diameter A beta fibers, which normally carry tactile and vibratory information from mechanoreceptors because both fiber types synapse within the substantia gelatinosa of the dorsal horn. In this manner, nociceptive signaling could be interrupted before reaching the brain by the application of a second stimulus. The first patient implanted with a spinal cord stimulator in 1967 received stimulation from an electrode within the thecal sac that was connected to an external pulse generator. Although the pain relief was not perfectly durable, alterations in the frequency of the stimulus were shown to renew the pain-relieving effect. At the targeted spinal level, pain relief is accompanied by paresthesia in the associated dermatomal region. Stimulation that is delivered at a frequency of 100 Hz or below has been coined conventional, and is thought to increase levels of the inhibitory neurotransmitter gamma-aminobutyric acid within the wide dynamic range neurons of the dorsal horn. The earliest indications for spinal cord stimulation included pain secondary to cancer, multiple sclerosis, and spinal cord injury. Spinal cord stimulation is also thought to improve microcirculation in the region of pain, as evidenced by its use in the treatment of angina pectoris and critical limb ischemia. 5 prospective randomized controlled trials investigated spinal cord stimulation as a treatment of angina pectoris with promising results. One of these was a multicenter, single-blind, placebo-controlled randomized trial in 2011. Among the differences demonstrated by the treatment groups relative to controls were reductions in the intensity and frequency of anginal episodes, decreased ST elevations during exercise, and improved quality of life. 2 additional prospective randomized controlled trials revealed higher limb salvage rates among critical limb ischemia patients treated with spinal cord stimulation compared to optimum medical management alone. 1 randomized controlled trial showed no difference. This forest plot was taken from a review published by Ubink et al. In 2006 summarizing the outcome of spinal cord stimulation studies of all types for critical limb ischemia and other microcirculatory diseases, such as non-healing ulcers and peripheral arterial occlusive disease. Cumulatively, 12-month amputation rates favored spinal cord stimulation over controls. By far the most common indication for SCS and the indication with the most supporting evidence is chronic lower back and extremity pain. 14 randomized controlled trials have been conducted for pain conditions that fall under this umbrella. Only one of these trials had negative results. A detailed table summarizing the individual studies and their findings can be found in the complete chapter. An additional 7 randomized controlled trials have been conducted for a more specific type of back pain known as failed back surgery syndrome. Failed back surgery syndrome, or FBSS, is defined as continued pain following 1 or more surgical interventions on the spine. Level 1 to 2 evidence based on the Cochrane review criteria was shown for the efficacy of SCS as a treatment for FBSS based on 2 studies. 1 high-quality randomized controlled trial performed by North and colleagues in 2005 comparing SCS to reoperation, and in the Senza randomized controlled trial for high-frequency stimulation. The Cochrane review criteria characterizes Level 1 evidence as a systematic review or 1 or more large double-blind randomized controlled trials. Level 2 consists of 1 or more well-conducted cohort studies, case control studies, or uncontrolled experiments. 2 multicenter randomized controlled trials were also conducted for the use of SCS for painful diabetic peripheral neuropathy, in one of which 59% of patients treated with SCS experienced pain relief compared to 7% of those treated with medical management. On the right is a visual representation of the results from a multicenter randomized controlled trial conducted in 2014 for diabetic neuropathy, showing the differences in scores on the visual analog scale and McGill Pain Questionnaire between SCS patients and controls. Additional pain conditions for which SCS has been used with less available evidence of efficacy include phantom limb pain, post-herpetic neuralgia, spinal cord injury, chronic reflex sympathetic dystrophy, occipital neuralgia, restless leg syndrome, pancreatitis, and pelvic pain. Sonic stimulation, also known as traditional or conventional stimulation, delivers consistent pulses at a frequency of 30 to 100 Hz with a typical pulse width of 300 to 500 microseconds and an amplitude between 2 and 5 milliamps. In contrast to conventional stimulation, newer techniques of high frequency and burst stimulation produce analgesia without an associated paresthesia in the dermatomal region of the targeted spinal level. Burst stimulation consists of groups or bursts of high-frequency 500 Hz pulses delivered at an overall frequency of 40 Hz. Stimulation delivered at a frequency of 1 to 10 kHz is termed high frequency. Initially, several randomized controlled trials and a pilot study showed conflicting results as to the efficacy of high-frequency stimulation for pain control, with 2 studies reporting no difference between high frequency and placebo. 5 out of 6 subsequent prospective randomized controlled trials, including the preliminary 12-month and 24-month follow-up analyses of the SENZA trial, have shown superiority of high-frequency stimulation to lower frequencies in placebo. 2 of these studies were blinded. With one high-quality trial demonstrating added benefit with high-frequency stimulation, level 2 to 3 evidence has been ascribed to the efficacy of this stimulation pattern. In humans, burst stimulation has been shown to improve pain levels relative to both tonic stimulation and placebo and was preferred by more patients in 4 prospective randomized controlled trials, 2 of which were double-blind. Considering the small sample sizes and short duration of these studies, the level of evidence for the use of burst stimulation was assigned as Class 4 or insufficient using the American Academy of Neurology Practice Guideline Process Manual and Level 4 using the Cochrane Review criteria in 2016. Since 2016, several additional randomized controlled trials with mixed results have been conducted. The diagram on the right was published in a review paper in 2019 depicting the additional activation of the anterior cingulate cortex and insula detected on EEG in response to burst stimulation compared to tonic. The anterior cingulate cortex and insula are thought to modulate the affective components of pain. Early on, spinal cord stimulator electrodes were unipolar, implanted directly onto the spinal cord, and connected to an external power source. Intradural placement of SCS leads was eventually abandoned for epidural placement due to the frequency of cerebrospinal fluid leaks, infections, vascular damage, hematomas, and scar tissue formation. Electrodes are now available in cylindrical and paddle-shaped varieties with varying numbers of contacts. Paddle electrodes, pictured on the left, provide a broader dermatomal coverage with lower power consumption. Both types of leads can be placed percutaneously or via an open surgical approach with laminotomy or laminectomy. Historically, implantation was undertaken under mild sedation to enable the patient to verbally confirm the location of the resulting paresthesia as being therapeutic. Lead placement under general anesthesia has emerged as an alternative, with electromyography responses in the desired dermatome serving as a proxy for verbal feedback. A recent prospective multicenter study found that placement under general anesthesia yielded lower operating room times, superior paresthesia coverage of the affected area, and equivalent postoperative pain ratings. Technical advances in SCS include units with limited MRI compatibility, implanted rechargeable pulse generators as opposed to external, position-adaptive stimulation, and closed-loop stimulation. Closed-loop SCS relies on the measured amplitude of evoked compound action potentials in the fibers of the dorsal column to maintain stimulation intensity within a target range. Dorsal root ganglion stimulation, or DRGS, emerged as a stimulation option to more precisely target focal pain that is challenging to address with spinal cord stimulation. A sub-analysis of the ACURATE trial, a prospective randomized controlled trial, revealed that DRGS covers a lower percentage of the painful area than SCS, but causes on average a much smaller area of unnecessary paresthesia. The same study suggested that the quality of pain control with DRGS was better in patients with complex regional pain syndrome type 1, as evidenced by a 94.4% improvement at 3 months compared to a 72.2% improvement with SCS as assessed by the Visual Analog Scale. In 2019, the Neuromodulation Appropriateness Consensus Committee published a literature review that evaluated the level of evidence of articles published between 1995 and 2017, according to the U.S. Preventative Services Task Force criteria. The results identified 1 Level 1 randomized controlled trial and 2 Level 2-2 observational studies suggesting DRGS as beneficial for complex regional pain syndrome types 1 and 2, with likely benefit but limited evidence available for other neuropathic pain syndromes such as FBSS, diabetic peripheral neuropathy, chronic postoperative surgical pain, neuropathic groin pain, causalgia, and phantom limb pain. The utility of deep brain stimulation for the treatment of chronic pain was discovered in the 1950s as a side effect of septal stimulation for the treatment of schizophrenia. Prospective multicenter trials in the early 1990s that were performed to gain approval by the U.S. Food and Drug Administration to use DBS for pain were unsuccessful partly due to trial design, small sample size, and early study termination. One trial achieved greater than 50% pain relief in 60% of patients 2 years after implantation, not including those lost to follow-up, however was terminated early due to low enrollment, high attrition, and low efficacy. These trial results have been heavily criticized for non-randomization, non-uniform patient demographics, unblinded assessment without objective measures, and inconsistencies in technique. Multiple meta-analyses have found that nociceptive pain is more effectively dampened by stimulation in the periventricular gray matter as opposed to the ventral posterior medial nucleus of the thalamus, and vice versa for neuropathic pain. This theory is supported by the observation that mechanistically, periaqueductal gray stimulation likely works through the release of endogenous opioid-like substances, whereas stimulation of the sensory thalamic nuclei and internal capsule work through some alternative yet unidentified pathway. Stimulation of the anterior cingulate cortex, in contrast, seems to work by modulating the perception of pain. The largest case series consisted of 16 patients and showed no statistically significant improvement on the visual analog scale overall, but statistically significant improvements in quality of life on the short form 36, which assesses physical functioning and bodily pain, as well as the EQ5D, which assesses mobility, self-care, completion of daily activities, pain, and anxiety. Patients tended to report more dramatic changes in mood and attitude about their pain than actual pain levels and often opted for a permanent implant, supporting the claim that anterior cingulate cortex stimulation effectively targets the emotional and cognitive aspects of pain. To improve the quality of data, recent clinical trials and case series have narrowed the focus to patient populations with a common cause of pain. Following the discovery of neuronal hyperactivity and increased density within the hypothalamic gray matter of patients with cluster headaches, the posterior hypothalamus became a target of interest for DBS. A randomized placebo-controlled double-blind trial found no difference in outcomes between 1-month periods of DBS and sham, but a subsequent 1-year open extension revealed that 6 out of the 11 patients experienced a 50% decrease in the frequency of attacks, and 3 were completely pain-free. After a stroke, up to 50% of survivors experience intractable neuropathic pain, commonly in the form of burning hyperesthesia over an area of decreased sensation. Various targets have been explored to treat this condition with DBS. A prospective, double-blind, randomized placebo-controlled trial with 9 participants who were implanted in both the ventral striatum and the anterior limb of the internal capsule for post-stroke pain did not show greater than 50% improvement on the Pain Disability Index in half of patients with DBS compared to sham. However, there were significant improvements in measures of affective pain such as the Montgomery-Åsberg Depression Rating Scale, Beck Depression Inventory, and the Affective Pain Rating Index of the short-form McGill Pain Questionnaire. A recent systematic review examined all case series of DBS used for pain excluding cephalalgias up to July of 2017, with more than 3 patients and greater than 3 months of follow-up. 22 reports with 59 patients were analyzed, with the degree of improvement varying based on etiology up to 89% and a mean follow-up duration of 27.9 months. Although DBS for pain remains an off-label therapy in the United States, DBS is approved for the treatment of chronic pain outside the United States based on expert opinion and patient testimony. A new development in DBS, one that may drive future advances, is the concurrent recording of brain activity with stimulation. This closed-loop stimulation may be used for early detection and prevention of side effects such as after-discharges that could precede seizures. Leads for DBS have also been developed that allow the care team to change which tissue immediately surrounding the implanted electrode receives the most electrical current by changing the orientation of the stimulation. This technique, termed directional DBS, allows for greater precision and individualization of treatment. Anticipated advances in DBS include the simultaneous stimulation of multiple targets within the pain network, an example of which is depicted here, advances in technical design that allow these targets to be stimulated at different frequencies, and the identification of new targets. Future avenues of research into DBS for the treatment of intractable pain should aspire to trials of adequate size with appropriate control groups, long-term follow-up, comparable disease states, well-defined parameters of success, and uniform implantation methods that are randomized, rigorous, blinded, and placebo-controlled. The exact mechanism by which analgesia is achieved with motor cortex stimulation, or MCS, remains unknown. Some theories have included a surrounding receptive field of inhibition from motor neurons that spreads onto the primary somatosensory cortex, the modulation of brain regions involved in emotional cognitive pain processing, the restoration of normal sensation through descending inhibition of hyperactive nociceptive fibers, and induction of the release of endogenous opioids. In 1991, Tsubukawa and colleagues used MCS to treat 7 patients with thalamic pain syndrome and 12 patients with deafferentation pain. The authors published that 45% of patients that received the treatment had sustained pain reduction for follow-up periods up to 2 years, which in their experience outlasted the analgesic effects of sensory thalamic DBS. Another case series in 1994 also demonstrated superior pain relief with MCS compared to thalamic stimulation. A literature review performed in 2001 that included 24 case series consisting of 272 total patients reported an overall response rate of 44 to 100% over follow-up periods ranging from 2 to 32 months. The authors concluded that although MCS seems to be an effective therapy for about 50% of patients suffering from neuropathic pain, it was difficult to predict who will respond to treatment. Several studies have suggested that different types of neuropathic pain, for instance central as opposed to peripheral, respond differently to MCS. Methods used to program MCS systems are not consistent. Recently, an ideal voltage has been identified as a percentage of the motor threshold, with one group identifying 62% as the value that optimizes pain relief. 6 randomized controlled trials have been performed since the early 2000s. 3 of these were double-blinded. One trial included only patients with a peripheral cause of neuropathic pain, and a 4th conducted by the same team specifically studied central post-stroke pain syndrome. 4 of these trials randomized patients to active stimulation versus sham with a crossover phase, followed patients out to 1 year, and used many of the same endpoints such as quality of life and emotional well-being. 3 of the 4 trials demonstrated clinical improvement during the active stimulation phase relative to placebo, with benefits still significant at 12 months. 2 of these trials reported that the strongest effects were observed with results of the McGill Pain Questionnaire that correlated with the affective components of pain. Stimulation settings among trials are highly variable, limiting the external validity of their conclusions. For example, a multicenter randomized crossover study in 2016 that was terminated for lack of efficacy has been highly criticized for using stimulation cycles in the treatment group of on for 10 minutes and off for 2 hours, which is not universally expected to produce clinical benefit. Since little is known about what determines the likelihood of response to MCS, some effort has been put forth into developing strategies used to identify responders. One group demonstrated that cyclized programming was not tolerated by non-responders due to increased pain, which may aid in identifying appropriate MCS candidates for permanent implantation. Additional methods used by other groups to identify responders to MCS are repetitive transcranial magnetic stimulation and double-blind testing during the trial period prior to implantation. Further research is warranted, but should proceed with careful consideration to address the sources of incomparability between previous studies, such as inconsistent surgical techniques and selection of patient populations with different types and causes of pain. Studies should also strive to recruit across many institutions to achieve sufficient power. Current use of peripheral nerve stimulation includes stimulation of the trigeminal ganglion, the trigeminal nerve and its supraorbital, infraorbital, auriculotemporal, and supratrochlear branches, the sphenopalatine ganglion, various occipital branches of the C2 and C3 nerve roots, vagus nerve stimulation, peripheral nerve field stimulation, and combinations of these techniques. Evidence for the efficacy of peripheral nerve stimulation is scarce, with occipital nerve stimulation, sphenopalatine ganglion stimulation, and peripheral nerve field stimulation being the only techniques backed by data from randomized controlled trials. A recent literature review used the qualified modified approach to grading of evidence to assess the level of evidence of various peripheral nerve stimulation modalities in relation to specific pain diagnoses. This table was adapted from A.B. Antony and colleagues' work and includes only the topics relevant to the scope of this chapter. Within this classification schema, strong evidence required multiple high-quality randomized controlled trials or 4+ observational studies or case series of high quality. Moderate evidence was supported by at least one high-quality randomized controlled trial, or at least 2 high-quality observational studies or case series. A rating of fair was assigned to evidence consisting of at least one high-quality non-randomized trial or observational study and multiple studies of lower quality. Limited quality consisted of evidence backed by multiple moderate or low-quality observational studies or large case series. The shared opinion of a large group of clinicians received a label of consensus-based evidence. Occipital neuralgia, as defined by the International Headache Society, consists of paroxysms of pain with or without dysesthesias in one or more of the regions supplied by the greater, lesser, or third occipital nerves. Occipital nerve stimulation, or ONS, pertains to the placement of an electrode within the subcutaneous tissue, usually transversely across the occipital nerve trunk to deliver electrostimulation. In 2015, a combined systematic review with evidence-based guidelines endorsed by the Joint Guidelines Committee of the American Association of Neurological Surgeons and the Congress of Neurological Surgeons was published that deemed ONS a treatment option for medically refractory occipital neuralgia. The authors backed the recommendation with what they determined was Class 3 evidence in the form of 9 articles, including 3 prospective case series, 1 retrospective cohort study, and an array of retrospective case series. ONS has also been used in the treatment of fibromyalgia, cluster headache, and most prominently, migraines. Cumulatively, across 5 total randomized controlled trials, patients receiving ONS for chronic migraine experienced 35 to 48% reductions in the number of headache days per month and decreased headache intensity as measured by mean daily scores on the visual analog scale. 2 prospective double-blind randomized crossover trials for the treatment of fibromyalgia pain with ONS included 38 implanted patients total and showed 33 and 40% reductions in pain intensity as measured on the visual analog scale during the trial period. One of these studies showed an overall 36% decrease on the Fibromyalgia Impact Questionnaire, which was maintained on follow-up at 6 months during the open phase and accompanied by a 50% improvement in quality of life. The proportion of patients experiencing an adverse event was high, ranging from 24 to 75%. These recent trials provide evidence that ONS is a viable option in the treatment of migraines and fibromyalgia, but should be considered only in refractory cases due to the high rate of adverse events. Stimulation of the trigeminal nerve or ganglion has been used to treat trigeminal neuralgia, post-stroke facial pain, post-herpetic neuralgia, cluster headaches, and facial pain of unknown origin with some success. A large single-center case series with 300 patients reported good to excellent control of trigeminopathic pain in 52% of those with implantation of permanent electrodes in the postganglionic trigeminal nerve, with lasting effects in all responders 1 year after implantation. Postganglionic stimulation is preferred over trigeminal ganglion stimulation based on a favorable safety profile, with 20 to 30% complication rates as opposed to 30 to 40% respectively. Several case series and reports have demonstrated the possible utility of stimulating the more distal branches of the trigeminal nerve. Supraorbital nerve stimulation, in combination with ONS, has also achieved larger decreases in migraine frequency and severity than ONS alone. On the right is a radiograph depicting the electrode positions in combined supraorbital and occipital nerve stimulation as published by Reed et al. In 2015. The first implantation of a sphenopalatine ganglion stimulator was in 2007 for the preventative treatment of refractory cluster headache. The patient became pain-free and complete reversibility was demonstrated as a result of a hardware failure. Later, a case series consisting of 6 patients examined the effect of sphenopalatine ganglion stimulation, or SPGS, as an abortive therapy for cluster headaches. 11 out of 18 attacks during this series were successfully treated. The only randomized controlled trial for the treatment of cluster headaches with SPGS was conducted across multiple centers and evaluated 28 of 33 implanted patients who received either full stimulation or sham during attacks. 67.1% of attacks treated with full stimulation resulted in pain relief versus 7.4% of those treated with sham stimulation. An analysis repeated at 24 months on all the patients that were implanted in this study demonstrated that 45% of patients responded to acute stimulation during attacks, and repeated stimulation of the sphenopalatine ganglion had the ability to reduce attack frequency. On the right is a diagram from the publication of this trial depicting a sphenopalatine ganglion stimulator with the electrode located within the pterygopalatine fossa and the fixation plate anchored to the zygomatic process. Also shown is a close-up of the device and the remote controller used for programming. Although most evidence supports the use of SPGS for the abortion or prevention of refractory cluster headache, case reports and case series exist detailing the use of SPGS in intractable migraines and various facial pain syndromes. Vagus nerve stimulation, or VNS, was approved in 1997 as an adjunctive neuromodulation therapy for the alleviation of seizures and has emerged as a treatment for medically refractory epilepsy. It was noticed that VNS reduced migraines in those patients with comorbid diagnoses, and a small case series demonstrated significant improvement in 4 out of 6 patients with chronic headaches. A retrospective case series of 10 patients with both epilepsy and migraines who were implanted with VNS demonstrated that 8 experienced a 50% reduction in headache frequency. One prospective uncontrolled pilot trial for the use of VNS in fibromyalgia resulted in 2 out of 14 patients no longer meeting the diagnostic criteria for fibromyalgia. No randomized controlled trials have been conducted for the use of VNS to treat pain, likely due to investigation into the effects of non-invasive transcutaneous VNS. Peripheral nerve field stimulation, or PNFS, stimulates small fibers within a focal area of subcutaneous tissue that may belong to branches of several larger named sensory nerves. This technique has been used for many different types of chronic pain, as illustrated by a large retrospective case series with 100 patients that included craniofacial, thoracic, lumbosacral, abdominal, pelvic, and groin pain. Patients who received lumbosacral PNFS for chronic low back pain in this case series reported a significant reduction in disability following treatment as determined by the Oswestry Disability Index. The first prospective randomized controlled trial was a crossover study completed by 30 patients in which significant differences were observed in scores on the visual analog scale between minimal, subthreshold, low frequency, and standard levels of stimulation. A later prospective trial of 13 patients looking at PNFS for lower back pain reported that at 24 months post-implantation, measures of pain levels, quality of life, and disability were greatly improved, and 92% of patients were able to reduce opiate consumption. One prospective double-blind randomized trial combined PNFS of the groin with SCS to treat post-hernia raphe pain and included a double-blind analysis during the 14-day trial period. All 4 patients experienced better pain relief with simultaneous stimulation compared to other types of stimulation alone. A prospective multicenter randomized controlled trial was also conducted for the treatment of FBSS with combined SCS and PNFS that showed 50% or greater reduction in pain on the visual analog scale in 43% of combined treatment patients compared to 4% of patients treated with SCS alone. Treatment of chronic pain remains a challenge for patients and healthcare professionals alike. The use of neurostimulation is now a large part of confronting that challenge. A more robust body of evidence is available for certain techniques over others, with spinal cord stimulation being by far the most studied and backed by clinical evidence. There are now multiple variations of electroceutical administration for spinal cord stimulation in terms of frequency, waveform, closed-loop adjustments, and location of administration. Other forms of neuromodulation for pain are deep brain stimulation, motor cortex stimulation, and peripheral nerve stimulation, which can be helpful in specific clinical scenarios. To accurately assess the efficacy of individual techniques, future study designs should be cognizant of including only patients with the same cause of pain, use uniform methods of treatment, control for confounding effects of adjunctive therapies, and make every effort to allow for the long-term follow-up of a sufficient number of patients, an endeavor which may only be possible across multiple centers. The associated cost and effort of such an undertaking is sizable, but should not serve as a barrier to the use of these potentially life-changing therapies.